Hello, everyone. My name is Jonathan Fritz. I'm the Chief Innovation Officer for Chime. It's my pleasure to welcome everyone to today's Chime Innovation Beyond the Edge. This is a 12-part series that's designed to share creative problem solving in response to COVID-19 and highlight innovations implemented by your peers. Today's session is Innovation at Intermountain Health during COVID-19. I'm very excited to hear from a great friend and CIO of the year, Marc Probst. He and Intermountain Health are great supporters and partners of Chime. Our first Chime Innovation Center was in partnership with Intermountain, something that would not have happened but for Marc. So thank you very much for that. A special thank you to DrFirst, our supporter for today's session. We know that each of you are very busy during this time, so we appreciate you joining. A couple of things I wanted to go over and really answer the question of why is Chime doing this presentation? Why is Chime doing this series? Change presents challenges, change presents problems, but it also presents opportunity. Opportunity for creative problem solving. That is, in my opinion, the core of innovation, and we want to celebrate the value and the good that comes from that. Chime members have faced many challenges, sudden remote workforce, spinning up and training clinicians on telehealth, infrastructure, resource constraints, restarting clinical, elective clinical procedures, and really now starting to think about what is a new normal. That next phase of this war that we're transitioning into. From what I've seen, our members and partners are some of the most creative problem solvers, really leading innovators. And as our good friend Marc would say, innovation isn't all about the BSOs, those bright, shiny objects. Innovation during this time, there's a lot of positivity and a lot of things that are impacting and saving lives. And those are the most impactful and the valuable innovations, period. So before we get started with the presentation, I'd like to cover a couple of details. Our session will have three main parts. The first one is a presentation from our speaker. The second, virtual roundtable sessions of 4 to 6 people. That will enable everyone to have candid discussions on the topic presented. And then the third is a Q&A with our speaker, Marc. For those that have attended in the past, the Q&A is new to this program. So please stick around for the breakout rooms as well as the Q&A session. So first we're going to hear from Marc, the CIO of Intermountain Health and also the CIO of the year. And after we have those roundtable discussions, we'll have a Q&A session. If you're unfamiliar with the breakout rooms, that's okay. I'll provide brief instructions prior to splitting participants into those breakout rooms. We'll have everyone muted during the session. If you like to ask a question, please use the chat function to alert the team. The chat window will appear on your right side panel. To ask a question, type your message inside the panel and press the send key. Questions for Marc can be posed in the chat function during the presentation or after we come back from the breakout rooms. I will ask the questions in the order that they were received. And so we'll try and answer as many questions as possible at the end of the presentation. However, there is a chance we won't get to everyone. If that happens, we'll collect all unanswered questions and send responses via email to the attendee list. Also, we are recording this presentation. This will be saved and stored on the Chime site, so you can go back and review any details once we finish. Discussions within the breakout rooms will not be recorded. If you have difficulty listening to the live audio stream through your computer speakers, keep in mind you can connect to audio via phone. If you need help with that or any other technical detail, please use the chat window and send us your questions. For those connecting via phone and your computer, please message the host with your name and phone number. Our host will then merge your phone and computer connections. Lastly, by attending today's full session, the presentation and the virtual roundtable discussions, you will earn 1 continuing education unit for CHCIO, CFCHE, and CHISL certifications. We will review the attendee list following the session and distribute CEUs accordingly. With that said, I'm going to hand it over to Kurt Hess, Senior Vice President of Sales at DrFirst, to introduce our speaker for today. Both Kurt and DrFirst have been excellent friends of Chime, and we really appreciate their support as one of our Innovation Beyond the Edge series supporters. Thank you very much. Kurt, take it away.
Thank you, Jonathan, very much. First of all, really want to thank Chime for putting these series on. They have been tremendously educational, at least for myself, being at what we do here at DrFirst, providing services around the country to healthcare organizations. I thought before just one comment I'm going to make. We've been offering telehealth services since this began, and received a note from a Marcy Showalter, who had been a clinician for over 40 years. And the comment she made, I just thought would be apropos for this. She goes, what was wonderful about telehealth with the nursing home folks was many of their expressions of delight when they saw Dr. Richter's face. Sure, the computer screen concept was foreign to many of them, yet recognizing a familiar face, greeting them all by name, and asking about each of them personally was so heartwarming. I think in this time of where we're tossing people around, stories like that are tremendously powerful. And I really want to thank all the clinicians and the folks that are on this call for all the hard work they've been doing to really make people feel like they're being taken care of. With that, I'm tremendously happy to introduce Marc Probst, Chief Information Officer at Intermountain Healthcare. He's a great friend of Chime and well-known innovative thinker in healthcare IT. Marc brings with him 3 decades of experience and 17 years of service at Intermountain. Over those years, he's championed numerous initiatives to transform health and patient care, including deploying agile development programs, creating a healthcare transformation lab, launching the massive genetics study Decode, and spinning off a new healthcare company. A lot of work. All of which make it easy to see why he has been named the 2019 CIO of the Year by Chime and HIMSS. I'm looking forward to what Marc has to share with us. So with that, Marc, I'll turn it over to you, sir.
Kurt, thanks very much. And for those of you on the phone, thanks for taking a little bit of time. As Jonathan said, I know you're really busy because we're all really busy right now. Some of us dealing with surges and lots of patients and full hospitals, and some of my friends in New York and Chicago, I mean, they are just hammered. Some of us in preparing for something that may or may not occur, but we need to be prepared for the communities that we serve. So again, thanks for taking some time. We've already been somewhat innovative because they asked me to drive this presentation, and I'm actually retiring in July, so I've been transitioning all my technology to new technology. Net of it is Jonathan's going to run the slides, and I'll try and do a little color commentary to them. But thanks for being here, and God, I wish we were in person. I so want to be with people again. My family is great. I love them. I think they're getting sick of me. But anyway, why don't you move to the next slide, Jonathan? For any of you that know me or have been to any of the boot camps or heard me speak, I love stories. And so I will start this one with a story. And this is a story about a little boy and a barber and a guy getting his hair cut. And that guy looks a little bit like Biden. I didn't mean that, but whatever. Anyway, this story, this little boy is peering through the window of the barber shop. And the guy getting his hair cut says to the barber, what's that kid doing out there? And the barber goes, oh, this is the dumbest kid I've ever met. The guy getting his haircut goes, well, what do you mean? He said, look, I'll show you. So the barber waves to the boy, and the boy comes running in. The boy comes running in, and the barber says to the boy, hey, I have a choice for you. You can either have this $1 bill or these 2 shiny quarters. And the boy takes the 2 shiny quarters and runs off. And the barber says to the guy whose hair he's cutting, he says, see? I mean, he does this every time. And so that was that. And the guy got his hair cut. And later that day, he's walking around town and he sees the little boy, and he calls the little boy and he says, son, you know, why do you do that? Why do you take the 2 quarters and not the $1 bill? It's only worth half as much. And the boy said, well, if I ever take the dollar bill, the game's over. So the moral of that story could be many, but in this circumstance, it's really about understanding the situation, listening to others, listening to what others are saying. What that man learned was a lot about that boy. That boy wasn't dumb. That boy had a plan. That boy had something that he wanted to accomplish. And what we do, whether it's being a CIO day to day, whether it's being some other part of a delivery system and what we do in healthcare, or if it's around innovation, it's all about listening to others. Jonathan said, well, Kurt's going to make you blush. And in some ways, that's so true, because I don't consider myself the most innovative CIO. In fact, I know lots of more innovative CIOs than me. If I have a quality in this space, it's because I'm willing to listen to others. And they have so many good ideas. You know, coming up with the Innovation Center at Intermountain Healthcare wasn't Marc just going, hey, we ought to get an innovation center. It was talking with Russ Branzell. It was over for me, a Coke Zero, but, for him, he was probably drinking something slightly stronger. And it was about, hey, let's talk about innovation. And then we came up with, hey, what if we had a center where we could bring people together and really share ideas? And that ultimately blossomed into, like Jonathan said, the first innovation center with Chime. And that's been highly successful. Until COVID, it was really successful. And I suspect post-COVID, it's going to be very successful again. But it is about listening to others. You can go to the next slide, Jonathan. So in the vein of listening to others, and we'll get to COVID in a minute, but again, I'm going to suggest so many of you have done way more than I've done, certainly, and likely way more than what we've done at Intermountain. But I do want to just talk about listening to others, as that story suggested. So when we got into the Innovation Center, we talked about, well, what should we do? And kind of at that point, we had a nurse that said, one of the biggest challenges was hand washing, and it's always been, right? Now we can use all different kinds of devices, but this is like 8-10 years ago, probably. And the nurse said, well, what if we created a watch that could tell if you washed your hands, or could tell if you used disinfectant on your hands by the way you rubbed your hands, or could feel the heat or whatever. And so we went about creating a watch that would do just that. It had motion detection in it, it had heat detection in it, and it could tell the various movements that were going on to suggest whether or not someone had actually washed their hands. And so as you can see with this watch, if it's red, this person hadn't washed their hands. If it's green, the person had washed their hands. We thought, wow, we're brilliant. We're going to make $1 bazillion off of this. And so, we created these watches. Net of it is, most nurses didn't want to wear the watch, and they don't want to, the doctors didn't want to wear it. So it wasn't a win for us, except for, and now you can go to the next slide, Jonathan. Are you still there, Jonathan? There we go, the next slide. We got involved in 3D printing to make those watches, because the parts weren't all available and we wanted some specific things in it. And so we bought ourselves, well, we actually ended up buying 4 3D printers, but we bought an early version of a 3D printer and started to make that watch and some other things. Well, that taught us a new innovative technology and thing. Again, I don't think many people at all were dealing with 3D printing at that point, but we had a reason, and we were able to get it. And we learned a lot. And so if you go to the next slide, Jonathan, it wasn't about making cool little toys like I showed in the last slide. And you can just click twice more and you'll get the rest of this slide. It was about how could we then take that technology and apply it to clinical care. And so there's just 3 examples here. Like I said, we have 3 now really commercial grade 3D printers. They're busy all the time because the clinicians are now getting the vision. They're seeing what they can do with it. And we're doing some very interesting things with it. So the one on the left is a heart. It's a baby's heart, a newborn that had some blockage and problems. And so prior to the surgery, you know, they could go in and look, the clinicians could go in and look at the image and they could decide what their course of action was going to be. But we built it in a way where they could tactily touch that and practice what they were going to do. And what was a very, very dangerous procedure, they were able to do very, very successfully, and have given a lot of credit to the work that the team doing the 3D printing was done. The second is a rib cage. It was actually our first clinical use of 3D printing, and it came out of a trauma unit where they said, you know, every time we get in, you know, not every time, but a lot of times in a car accident or some kind of a bike accident or something, ribs are broken. And what we have to do with these ribs is we have to go in, open the body up, and then take plates and, you know, actually form these plates during that surgery to hold the rib cage together. And, you know, it takes some time. They were wondering, well, what if we created a 3D model of it? Then we could actually pre-create those plates so that they fit exactly. And then we wouldn't have to spend that additional time inside the person and get that done. Again, very successful and a wonderful way of using that technology. And then the third one, that is a kidney, I believe, and it was a woman. That one actually got in the paper here in Salt Lake City because it was a very complex surgery, and we were able to create the model of that organ. And again, they were able to practice it prior to going in, and it was an excellent surgery. And, you know, we got all the news, and now Marc looks like he's really innovative. And like I said, it was really more about listening to others and the things that they could do. And that got us into 3D, and that got us into the things that we're looking at here. All right, Jonathan, we'll talk a little bit about COVID. Most of the innovation, you'll see a couple cool things at the end of the, you know, this deck. Most of this is pretty technical and probably pretty boring, but this is what we dealt with, all of us in IT. We dealt with the fact that things had to change. So iPads to use in patient rooms that we didn't want clinicians going in and out of because we didn't want to be spreading the virus. And so we configured a ton of iPads and a ton for, you know, probably like most of you, visits to our hospitals went to, you know, almost zero. And as we did that, we needed ways for patients to be able to talk to their families and other loved ones. And so we installed a ton of tablets, video visits. Again, I'm preaching to the choir, I know I am, but, you know, what was a kind of a nice to have thing in doing video visits became mandatory because we closed our clinics. And so we installed over 1,000 devices to support scheduled video visits, something we wanted to do and we had begun, like a dozen maybe, turned into 1,000. And we needed it not to just work from clinics, but from homes, and homes where they didn't necessarily have the devices to do it. So we just deployed over 600 other additional laptops. And actually that number's pretty small. It's much bigger than that. And all of this had to happen really, really quickly. We redeployed resources. So there were some resources that just couldn't do their jobs as well within their current job in IT. And so but we did have huge needs to take all these devices and stuff and get them out and get them serviced and get them supported. And so we took 14 of our employees and redeployed them to a different area. And, you know, you can see all the things that are there. VDI, I mean, holy cow. We were prepared for people to work from home. We weren't as prepared to take on, I think it's like 18,000 non-clinical caregivers that we needed to move into home and do their job because of Select Health, our insurance program. We have several partners that also needed to work from home. We're very involved with R1, the revenue cycle company, and they had a couple of thousand employees they needed to move home. So what a fantastic, whether that's innovative or that's just hard work, I think there was a lot of innovation that went in to making these things happen so quickly. And kind of a note to all of us, things that used to take 6 months to happen were happening in 6 hours because the demand was there. Shows what we can get done if we're not bogged down with a tremendous amount of bureaucracy. Okay, go ahead, Jonathan. And I'll go through these pretty quickly, but the wide area network. You know, again, we've got like 100 gig lines that go through microwave between our various facilities. I'm sorry, 100 meg lines that go between it. They're all over because we live in the mountains, and so we have these things we can bounce it off. So most of our facilities were in that. That sucker choked in no time at all. And so you can see we upgraded everything from 2 gigs to 10 gigs, from 5 gigs to 10 gigs, and really working to get a wide area network that would support the things that were going on in our facilities. And that, again, that wasn't just about clinicians. That was about people that wanted to visit their family. That was about children up in Primary Children's Hospital that couldn't have but maybe one person with them. Now, some of that is eased, but that's kind of the world that we lived in. So massive amount of work on our wide area network. Go ahead, Jonathan. I would click through these faster if I had control, but we'll blame Jonathan. You know, the McCady Hospital is about 40 miles north of Salt Lake City, our Lake Park data center, which is on the left. And those are our 2 primary data centers. Well, we were at 2 gig and it was choking. And it wasn't just the internet itself or the pipes itself. Our firewalls were not at all sized to handle the kind of increased function or use that we were getting. And so we saw a lot of very innovative changes to multiply the capacity of those firewalls and the things that we're doing. Go ahead, Jonathan. Most of this is going to be network because network is what we did with, you know, look at each of our facilities. This isn't all of our facilities. This is a representative just to give you an idea. We have 28 facilities plus an insurance company, a home health company, and we just bought a clinic in Las Vegas. And I was so impressed, not just with the team and their ability to get this work done and ability to look through all the pieces that, you know, it's never one thing, right? I mean, if you go and up all your bandwidth, that's going to create problems in other parts of your operation and how they work through that. But so impressed with our partners who came to the table, just willing to help. So many of them did work and it was like, we're not charging you for this. We're part of the team to get it done. That's a lasting kind of thing that I'm really just impressed with and pleased with the kind of reception that we got. Go ahead, Jonathan. And go ahead. I mean, there's just more facilities that we did. So 25 circuits were upgraded via COVID. We aggregate the aggregated bandwidth that we now have is 33.4 gigabytes per second. That's pretty close to Back to the Future. We have 22 new networks, you know, like everyone else, and you'll see a couple pictures in a minute, but we had to build out curbside testing. We had to build field hospitals. And I'll show you a picture. We even have the RV that we always used at HIMSS for when people came to visit us at HIMSS on the floor. That RV was, within a week, was transitioned from that kind of a demo type of a situation to actually a screening center where we could go to rural parts of our operation and get testing out there. And that's been really successful and important because we're a big state. We're, big land mass. We're about 3.5 million people in Utah, but about 1.5 million, maybe 2 million live in about 3 population areas here in northern Utah. All the rest of it spread out across the organization. It wasn't just about networks, and I guess Jonathan's moving me right along, man. It's not just about networks. A lot of innovation around the use of our clinical information system, a lot of alerts. We needed to put in new workflows. We needed to add new technology. Craziness of, you know, we use a major vendor to do most of our telehealth through. It's our clinicians, but we use their technology. We weren't capable of scaling that up. So, you know, now we're using FaceTime. Now we're using Google Duo. Now we're using Zoom. And then we started looking at all the issues that come with that because of security and privacy and how do we get past that? Thankfully, the HHS gave us a little bit of relaxation around those things. But I imagine on the back end, we're going to be paying for that in work that we have to do. But, you know, you can see around nurse and clinical documentation, physicians documentation, how people order. You know, we didn't have COVID tests pre-COVID, but we need to build those and get those in and make sure that they were done in a way that we were only testing the correct people. And that goes into diagnostics and problem lists and our ancillary services. I mean, our labs, not only did our labs get hammered like everyone else's labs, but we have partners that do a lot of our lab work. And we needed to make sure that the connections to those new partners would work and that we could do it in a safe and secure way. And we're kind of best practice care, clinical decision support has always been important at Intermountain Healthcare, and we built several new CDS capabilities based on COVID. And I consider that all very innovative. Go ahead, Jonathan. So, this is the graphic part of it. Up on the upper left-hand corner and in the bottom right-hand corner, actually, that is our mobile testing center. That was the RV that we used to see at HIMSS. That, again, we do more testing in that at this point than we do within our curbside or within our facilities. So, and just to, again, to put it in context, in the state, we've had under 60 deaths. Our hospitals are definitely not like New York and Chicago where they're just full. But we have to prepare that could happen here. They're suggesting our surge might be in July. And we'll see. Maybe a lot of the things that everyone is doing is helpful. On the bottom left-hand side, we wanted to look at a way we could isolate the COVID patients so that they would be less likely to spread the disease, particularly in a field hospital setting, which is the one in the middle, where you don't have individual rooms that you can put people in. And so a team of clinicians and a team from IT, which is the group I manage, they built those two prototypes on that bottom left-hand side on how we might isolate those patients, still, keeping them relatively comfortably. No one would want to be in a tent like that, but no one wants to have COVID either. And came up with that in about 48 hours. And the one that won the day was the one on the left, the plastic one, or the more sheet plastic than the hard plastic. But a lot of that happened because we've done a lot of innovation around NICUs and how we could isolate NICUs and how we could put cameras into those kind of things. So we didn't come into it unexperienced. We came into it with some experience, and I thought that was very innovative. The field hospital in the middle, that's kind of cool. The way we did that is the upper right-hand picture, which is a room where we simulated the field hospital in the auditorium in our data center. And we spent 3 days doing that. Some of that was how would workflow work. Some of that was how could we get a good network there and make sure that it would work, correctly within the field hospital outside, where you're getting a little more dispersion of the signal itself. And that has been very successful. I don't think we've had more than 3 or 4 patients actually use the field hospital, and I pray that we don't ever have anyone. So all of these are ideas that came from others. All of these are things that we could take the skills and maybe the discipline that we've created around innovation and apply it and have things happen very, very quickly. Okay, Jonathan, let's go to the next slide. And this is another story. This story is about a guy that had a bunch of equipment, a bunch of product that he had created in one city. And this is back in the horse and buggy days. And he needed this product moved from one city to the other. And it was over a mountain, and the roads were very treacherous. These aren't the exact roads. I think this is southern Utah. But it was, it was a important job, and he needed a contractor that he could get to do that work. So he put it out for bids, and he got 3 people to bid on it. And the first guy came to him and said, man, I have got a really fast cart. I have good horses, and I can do this job. And by the way, I am so good. I've done this a number of times. I can do this quickly, and I can come within a foot of the edge and never have a problem and take your things safely to the other town. Guy goes, that's pretty impressive. The second guy came in and said, I've done it a lot of times. I got great horses, great cart as well. And you know what? I can get within 6 inches of the edge and never have a problem. The guy goes, wow, that's really impressive. The third guy comes in and says, I got a good horse, I got a good cart, And I'm going to stay as far away from that freaking edge as I can. Well, a guy obviously hired the third guy who is going to be careful with those important products that we need to move through. How does that apply to innovation? We do take risks. We do need to do things quickly, but we also have to keep safety and security in mind and just be smart about how we do innovation. You know, it isn't the watch that made the big difference, right? That ultimately didn't work, but it was the fact that we could do 3D printing. It wasn't the fact that we could code or create good clinical decision support. It's how we could apply that knowledge to a problem that was very urgent to us at the time. That's what made us successful. All right, Jonathan. Keep going. So why do we innovate? I mean, this is a mortality rate slide, and I didn't have I'm sure I could have gotten a better one, but you know, think about how COVID is impacting different countries around the world. Think about how, you know, China has had the problems it's had, or even parts of the United States. We innovate so that we can smooth this out. We're going to innovate, I think, quickly to get to a vaccine. We're innovating how to get to better treatments for COVID so that we can start to bring our world back to something that's normal. Why innovate? Because there's so much disparity. Why innovate? Because there's so many needs around the world. And it takes many people to come up with the good ideas and deploy those ideas. One more slide. And it's around why to innovate. This is my daughter, Heather. You can see my daughter, Heather, has Down syndrome. She is in the hospital at this point because she came down with leukemia when she was 11 years old and dealt with that for about 7 years. She died when she was 17, and it was the third round of leukemia. Why innovate? We innovate for people like Heather. We innovate for people that we can make a difference in. She lives, we are sure, she lived 6 years longer than she would have because of the way the disease treated her. When she first got her first treatment, it didn't work at all. In fact, her numbers rose dramatically after her first set of chemo treatments. But the innovation, the ideas, the creativity, the clinicians got her onto a protocol that actually twice got her into remission. And the third time the disease took her. But this is why I innovate. This is what's important to me. It's people, and it's how we can apply the things that we've learned. So my biggest points are innovation happens because of others. The ideas come from others. Our motivation comes from others. If we're doing it for the right purposes, and even if you're not, even if it's just a financial innovation, there are purposes to do it. My purpose is because I want to help the community I work in. I want to help sick people. And I've been so honored to be able to do that now for 17 years at Intermountain Healthcare. And that's the end of my remarks, Jonathan.
Mark, thank you very much. Each one of your presentations that I've seen, you always end on such a meaningful note and really appreciate it. Also, I'll be your IT backup anytime you'd like. So thank you very much again. All right, welcome back, everyone. Hope you enjoyed the discussions in the breakout rooms. Just as a reminder, we're going to have a few minutes here before the top of the hour to do a Q&A with our good friend Mark. Feel free to send any questions that you might have in the chat function. Mark, I've got a few questions I'd like to start off with until folks start putting them in. You've got, if I recall correctly, pretty close to about 1,000 folks in your department? Maybe just a little bit less than that or so?
No, it's actually about 1,200.
1,200, okay. What did you see as, you know, the most impactful reaction of that? I mean, that's a pretty sizable group that you've got there. What was the most impactful reaction to COVID-19 that you saw from your team members?
I'm not sure I understand reaction. I mean, it was more action.
Mm-hmm.
I'll tell you the thing that struck me, and may not answer your question, but like all of you, we spun up a command center, right after we started seeing COVID come in, and daily calls. It started at 8 a.m., went to 2 a.m. or 2 p.m. and we had these section leaders, and everything was broken down into sections. And so the operations lead is a physician, and they're working with operations. We have one that's dealing with communications, and I won't go through all of them, but all these different pillars. And it was really interesting to see how at first those groups struggled a lot. And when we got together in the IT section, I was meeting with the leaders in that group, and I said, this is nothing. This is what we do every single day. It's a different problem, certainly, and we're not the key to it. Like if we're doing a Cerner implementation or an Epic implementation, we're in the spotlight, we're getting it done. But this is similar to that, right? A rollout of a major technology or something, a big project that we're doing to modify workflow or whatever it might be. This is like that. And our team came together immediately. They knew exactly how to do it, how to set up the communication channels. We had the team sites all set up so that we could communicate with one another. When people went home, we really didn't miss a beat. And I thought that was just amazing, first of all, and very, very proud of my team. My team came together about just a little less than 2 years ago, and it's a long, sordid story. I won't go through why it came back together, but it came under me. And I knew I was retiring here in a couple months back then. And, I really wondered, would we, when I leave, and not that I'm not any big deal, but would that team be ready? Would they be working together? Would they be communicating together? Would a lot of the pettiness be gone? And this has been so heartwarming to me to see how they're pulling the load. And when I go, whoever comes in, it's just going to keep going. And I thought that was terrific as well. So, there are silver linings to it, Jonathan, but it was the teams coming together that probably struck me the most.
Thanks, Mark. We've got one question from Alir, who's a good friend of Chime, has attended some of our innovation events. He asks, did Intermountain do something on contact tracing within the clinician's workforce? And then is the presence in COVID high-risk area tracked as well?
So not a lot. I mean, we're involved with the states. I work really closely with Jim Turnbull up at the University of Utah, and we're involved obviously in the state because we're the largest employer in the state. And most of that is being handled at that higher level. We haven't done anything really specific, although the state has developed a fairly invasive product that does contract tracing through the iPhone. And we'll do the contract tracing of if we find a patient, it's infected a clinician, and we'll do all the tracing that way. But again, we've had relatively small numbers of cases, and certainly much smaller that have been inpatient cases. So I would not consider us experts in it, but we are we're working with the state, and I think we'll see it become more mature over the next month.
Thanks, Mark. In your presentation, you mentioned that Utah, I believe it was potentially July is when you might see your peak. Is that what they're projecting?
June, mid-June.
Mid-June, okay. What sort of planning do you have or have you undergone for post-peak? And whether you call it a new normal or you call it, taking down the field hospital or, just adjusting all of the hard work that has been done, in order to be able to address the peak concerns or peak needs.
So each one of the section chiefs is getting together to, one, make the determination on, so our state went to orange. We went to orange about a week after the state did, so that we could start some elective surgery, but there's some pretty tight criteria on it. And so the section chiefs are each working on their own plan post-COVID. I would say the biggest thing we've done in CTIS is to create a COVID registry for all the changes that we made. I mean, we have definitely relaxed consistent with what the government's allowing us to do, but relax some of the technology management processes and requirements that we had in place before. And so we created this registry that allows us to look at what we've done so that we can build the plans to back out. But, you know, we're a month and a half from when our projected peak will be. So we're relatively early on creating those plans, but we definitely have them. And another thing we did is we got a lot of equipment that went into people's houses. And that created its own security issues, but also creates an issue on tracking the assets. And again, part of that registry is making sure that things return to where they should be and that we get to the new normal. I think it'd be interesting to see what our offices look like. I mean, we all built really open offices so that we could collaborate and work together and not have walls. And now we're going to look at it and go, yeah, well, if you don't have a wall, you're going to have to wear a mask. And interesting to think how that changes things.
Thanks, Mark. We're almost out of time here. Is there any last words or any last comments that you'd like to leave our attendees with?
Just thanks. Thanks for being part of this, the breakout session. I met 5 terrific people and had a nice conversation, and appreciate meeting you, and thanks for listening, and be safe.
Great. Thank you very much, Mark. Couple of closing comments.
Can I share some pictures of Keith?
No, you may not. I almost escaped. Hurry this up, Jonathan.
That's always encouraging, Mark. We'll be sending out an email to everyone that's attended, so we really appreciate it if you would answer the survey. This is a new program, and would love to find out if it does or does not meet your needs. Would like to thank DrFirst and Kurt Hess once again for supporting Innovation Beyond the Edge. A couple of events that we've got coming up. On Monday is our 7th session for Innovation Beyond the Edge. Dr. Natalie Pagler from the CMIO at Stanford Children's Hospital. Next week, we've got a virtual happy hour at 6 p.m. Eastern Time on Wednesday. Please join that. It's just for Chime members. And next week, Friday, we'll hear from Keith Perry, the CIO of St. Jude's for Innovation Beyond the Edge. So please register for those sessions. Last but not least, thank you again for your time and your attention. We really appreciate you being able to join us, especially when you've got 23 other million things basically vying for your attention. So have a wonderful day and be well.